Welcome back, students, to another lecture of Introductory Psychology. Today we're going to talk about what many students are to start taking Intro Psych for, and that is to learn about psychological disorders. And a tendency for many people is to, once you learn about psychological disorders, is to start to diagnose yourself and others. Please don't do that. Diagnosis is a process that's fairly exact and depends upon some very specific symptoms that we'll talk about in almost any disorder. So when you see certain traits that you believe you can identify with the symptoms of certain disorders, pause and think about it, and maybe go back and look at DSM 5 or even look it up on Google for that matter. So today we're going to talk about psychological disorders. Before we talk about what any disorder is, we have to talk about what's normal, because if it's a disorder, that means it's going to have to be outside of normal. So what is normal? Definitions. What is psychopathology? What is a pathology? Psychopathology is a scientific study of mental, emotional, and behavioral disorders, and it is an abnormal or a maladaptive behavior. Statistical abnormalities having extreme scores on some dimension, like intelligence, anxiety, or depression. So when we talk about abnormality, one of the first things we want to look at is it statistically abnormal within the context in which we are observing it. So so in this curve, in this normal distribution, normal might be right in here, like in plus or minus 1 standard deviation is what we might consider normal, or we might even go out to 2 standard deviations and consider this statistically normal within this distribution. Social nonconformity is disobeying societal standards for normal conduct, and it usually leads to destructive or self-destructive behavior. So, and this cartoon there on the right, like, mom, what's normal? Yeah, it's just a setting on the dryer, honey. So, you really have to operationalize normal. I mean, more than define. It has to be operationalized. You have to see it within a certain context every time. So a situational context is a social situation, it's a behavioral setting or general circumstances in which an action takes place. So in other words, is it normal to walk around naked among strangers? Well, if you're in a locker room or in a shower area, then yes, it is normal. So it's within context. Cultural relativity or judgments that are made relative to the values of one's culture. Many times people make the error, naturally so, though, that cultural relativity speaks to truth and good, bad. No, it needs to be, it's all relative. Subjective discomfort or private feelings of pain, unhappiness, or emotional distress. So let's talk about the core feature of disordered behavior or maladaptive behavior. It's difficult to function or to adapt to the environment and to meet everyday demands. When graduate students take psychopathology with me and learn how to do diagnoses and write treatment plans, I make everyone memorize this definition of a mental disorder. I'm just going to read it now. A mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, that's thinking, emotional regulation, or behavior that reflects a dysfunction in psychological, biological, or developmental processes underlying mental functioning. And it's an expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. So grieving over something for a period of time that's normal within one's culture, that's not a mental disorder. And feeling very depressed or blue over a loss, or feeling excited over a gain or an accomplishment. It's just if it lasts too long, that's where we run into the problem. And it's not even too long. It's a matter of functioning, how you function. Okay, so what is insanity? It's a word that we hear, but we really don't use it a lot. It's a legal term, and it refers to an inability to manage one's affairs or foresee the consequences of one's actions. So those judged insane by a court of law are not held legally responsible for their actions. They're not legally responsible for their actions who are judged insane by a court of law. But they can be involuntarily committed to a mental hospital, and this is established through testimony of expert witnesses. Now, you may have watched TV shows or law shows where programs where there's testimony about somebody's insanity, the insanity defense. And of course, both sides, the plaintiffs and the prosecution, will bring forth their experts to combat and say, well, this person was insane, this person was not insane. So again, there's no hard and fast truths to some of these issues. What's insanity? Here, the person can't distinguish from fantasy from reality. That's one good definition of insanity from a legal point of view. Can't conduct his or her affairs because of psychosis or some kind of uncontrollable, impulsive behavior. So, not guilty by reason of insanity is that the accused, due to some diagnosable psychological disorder, is unable to appreciate what she or he did, that whatever she or he did was wrong. So being diagnosed with a psychological disorder does not automatically imply a successful insanity defense. So not guilty by reason of diminished responsibility applies to other situations or cases of intellectual disability like Down syndrome or some form of brain damage. How do we classify mental disorders? And if you can see there's the DSM-5 there on the right. And we have gone through the 5 so far, and each one also has had revisions. So there's been, I started in DSM-3R. Then it went on to DSM-4, DSM-4R. Now we're in DSM-5. There may be a DSM-5R now. It's going to be coming out really soon if it's not out already. So in the context of the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, a disorder is a significant impairment in psychological functioning. What are some of the types, vicious categories, domains of psychological disorders? And then we're going to go in and look at these more in more detail and list a lot of them, although we're not going to actually get in there and start doing diagnoses. So psychotic disorders, and these are severe mental disorders, and they're characterized by hallucinations and delusions, social withdrawal, a move away from reality. We see this mostly with schizophrenia. There are organic mental disorders, and these are mental or emotional disorders or problems that are caused by some form of brain pathology. So that's more organic, more cellular or physiologically pathological. Then there are a set of disorders called mood disorders, and these are major disturbances in mood or emotions like depression or mania and many different types of mood disorders. There are anxiety disorders, and these are disruptive feelings of fear or apprehension, panic, and other types of behavior distortions. Then there are a set of disorders called somatoform disorders. Remember, I said anytime you see soma or somatoform, that refers to something of one's body. So somatoform disorders, they are psychological disorders, So they are physical symptoms that mimic disease or injury, like blindness or anesthesia, and there's no identifiable physical cause, because your brain can do these things. Then there are a set of disorders called dissociative disorders, and these include temporary amnesia, multiple identity. The old multiple personality disorder falls under dissociative disorder, although we call it multiple identity now. Depersonalization, like being in a dream world or feeling like you're not yourself, like you're in a robot or outside your body or something. And these can be quite severe. Then there are personality disorders, and these are deeply ingrained, unhealthy, maladaptive personality patterns that the individual with a bona fide personality disorder just takes that everywhere, every single context, every single problem, every single social environment, culture, whatever, that personality that gets applied everywhere. Sexual and gender identity disorders are problems with sexual identity, deviant sexual behaviors, or sexual adjustment. Substance-related disorders are abuse or dependence on a mind or mood-altering drug, alcohol, cocaine, THC. Then there are culture-bound syndromes. These are syndromes or disorders that one will see only within certain cultures. This one, we use this term sometimes if somebody's acting very, very wild and unpredictable. We might say that they're running amok, and this term is a term that in fact is a disorder that comes from Indonesia and Malaysia. And this individual suddenly withdraws from family and friends and then bursts into a murderous rage, attacking the people around him with whatever weapon is available. So there's that. There's some others: amok, susto, ghost sickness, korozar, dat, and hikikomori. Then also there's bulimia. Now you'd think, bulimia, that's a culture-bound syndrome. Yes, it is. And it's a syndrome pretty much bound to Western cultures like the United States. You do not see bulimia in a lot of other cultures. So the DSM-5 defines mental disorders, and these definitions change over time as we learn more. And as normality seems to shift one way or another, and it does, normal is never constant, the definitions of mental disorders change over time. We used to have, and you still hear this term, we use this term quite a bit, but the term really came out of the Freudian era, and that's called neurosis, and it's outdated. And we use to group anxieties and somatoform disorders and dissociative disorders, other kinds of depression. In fact, depression used to be called depressive neurosis. Before that, it was called melancholia, but that I think was even before DSM-1. New definitions and new mental disorders can be added to DSM-5. They are often added to DSM-5. Post-traumatic stress disorder, melancholia, apathy syndrome, internet addiction are among some. And there are others that are simply that are being researched that could possibly be added as new disorders. Certainly, also disorders that exist now that are in there can be removed or modified. So what are some of the general risk factors for developing a mental illness or mental disorder? Just look at what makes one potentially more accessible or to a psychological disorder than others. Well, there's biological factors like genetics. Psychological factors are there as well. Family factors, your family and who you are around, mostly, especially in your very, very early years, also has a great influence on one's development. So family factors, parents who are immature, mentally ill, abusive, criminal, substance abusing, poor discipline, marital and relationship problems, all of these things have a great effect on those being raised with them. And then there's, of course, of social conditions, poverty, homelessness, overcrowding, stressful living conditions. All of these factors blend and combine and interact uh, to make one susceptible to any number of mental disorders. And as I said, some disorders, they don't even exist anymore. And I put one of the most extreme ones here on this slide. And these terms are also easily abused. Now, obviously, in the 19th century, there was no DSM-5, but here's a ridiculous disorder. Drapetomania. It was a mental disorder that causes slaves to run away. And anarchia is a form of insanity that leads one to seek a more democratic society. Again, these are sort of like fantasy disorders, I guess you'd say, that are used to make it okay. Let's remember these things, and this is important relative to disorders. We need to label problems and not people. 2 or 3 decades ago, we stopped. For example, you don't call somebody with schizophrenia schizophrenic, because that is associating a disorder with that individual. That is a patient with schizophrenia. Or we don't call somebody with depression a depressive. It's somebody who's depressed. Remember, and I mentioned to you earlier, don't start running around and diagnosing everybody. And indeed, that's called medical students' disease. As psychology students, you're going to notice that when you see some abnormal tendencies in your own or others, they're going to start to, oh, what is that? What is that? So that's okay, but think about it once you get to that conclusion. And then, of course, this cartoon below that says, take psychology class, learn about mental illnesses. Oh God, I have all of them. Okay, let's start talking about the most severe or serious group of mental disorders, and those are the psychotic disorders. What is psychosis? It's a loss of contact with shared views of reality. Note that, contact with shared views of reality. So, of those 4 groupings of those things that we share with reality, those are hallucination, delusion, thought disorder, and insight. What are some types of delusions? There are depressive delusions, believing that you've committed horrible crimes. There's somatic delusions, believing that your body is rotting away or that it's emitting foul odors. There's delusions of grandeur, believing that you're extremely important. There's delusions of influence, believing that you are being controlled or influenced by others or by unseen forces. I'll give you an example of this. When I used to work at Cameron State Hospital, it was a very large state mental hospital, and I spent about half of my time on the schizophrenia unit in the schizophrenia ward, and the rec room. Then we call that the day room. The patients sat around in the day room, and I'd spend a lot of time just sitting in the day room watching TV with them and socializing. And there were a couple patients I remember who believed that when they watched TV, that there was influence coming out of the TV in terms of rays or something that was getting inside their head. Ideas certainly come from the TV and get it, and we do it, but they're not like they're not involuntarily forcing themselves via little types of bullets or any kind a germ that gets in there. And I've heard all of these different types of ways in which one has a person with schizophrenia has delusions of influence. There's delusions of persecution, believing that others are out to get you. Delusions of reference, and that is you give great personal meaning to unrelated events. Like a couple of things happen, and then all of a sudden there's some connection between the two, and then there's absolutely none. Now, other symptoms of psychosis include what we call flat affect. And this is just a lack of emotional responsiveness, disturbed verbal communication, word salad, garbled speech, personality disintegration. This is when the thoughts, actions, and emotions are no longer coordinated. We're used to seeing motions, actions, feelings, all being in coordination. But you ever consider what it looks like when it's not? Then there are organic psychoses. Dementia is certainly an organic dementia. Alzheimer's disease, where Ronald Reagan was the most famous Alzheimer's victim. There are delusional disorders. So a delusional disorder is marked by the presence of deeply held false beliefs. You cannot argue or argue with somebody with a delusional disorder, and they are very difficult to treat. So delusions usually are not so bizarre as they could possibly occur as in the case of other psychoses. So these delusional disorders, that's basically what the person has, and it is within a cognitive domain. So it's not to a point where many times not to a point where the individual can't function in society. Then we have something called paranoid psychosis, and this is the most common delusional disorder, and it centers again on delusions of persecution. You might find somebody with a paranoid psychosis, or at least with a delusional disorder, as somebody who's highly skeptical, very vigilant, hyper-vigilant, he's always looking around, and doesn't trust anybody. What are some of the types of delusional disorders? There is the erotomatic, and that's a delusion. The other person, usually of a higher status, is in love with the individual. Erotomatic, I mean. And we'll see this a lot when somebody stalks a famous celebrity. There's a couple of cases like that. Grandiose delusional disorder, persecutory, jealous, somatic, mixed, unspecified, so on. Schizophrenia now is a psychotic disorder characterized by hallucinations, delusions, apathy, and this, by the way, and Hollywood gets this wrong all the time. Schizophrenia is not a split or multiple personality. It is not. Schizophrenia is not mania or bipolar disorder. Okay, and like I said, Hollywood, they get this wrong all the time. There's different types of schizophrenia. Paranoid, catatonic. These terms, sometimes they don't. You're not going to find these in DSM 5 anymore. Hebephrenic, which is in the ICD, or disorganized schizophrenia is in DSM 5. Undifferentiated schizophrenia, residual schizophrenia. So again, these terms and what we learn about these disorders change, or the level to which we consider them more or less severe changes as well as we learn more. These changes just aren't random and haphazard. Changes in the DSM-5 are due to extensive, quantitative, verifiable, valid, and reliable research. Some causes of schizophrenia could be some sort of psychological trauma. It could be a disturbed family environment. And you often will see this in areas or within people where there's some sort of there's a deviant communication pattern that tends to cause guilt or anger. It seems to be wrapped up in that. And whatever is said or communicated, there's always some blame or guilt or something or anxiety or you in the communication. So there's certain family theories about schizophrenia. One thing that needs to be very clear: schizophrenia is a disorder that is global and tends to not be culturally, only culturally grounded. Now, you'll see it expressed in different ways in different cultures, and in some cultures, schizophrenia is not considered as serious as in our culture, but across the globe, there's about a 1% prevalence of schizophrenia. We don't really quite know what the cause of it is yet. The brain chemistry is also obviously a part of the cause, biochemical abnormalities. I know also in reading some early research, it trying to look at the relationship between a psychedelic drug like LSD-25 and an individual and people with schizophrenia, and LSD-25 does not cause the same types of hallucinations and delusions that is schizophrenia. In fact, you can give somebody with schizophrenia LSD, and they'll say, "What's this? This is different. What's this that you gave me?" Dopamine overactivity may be related to schizophrenia, and many of the neuroleptic drugs, the psychoactive drugs that we use for schizophrenia, do in fact have our dopaminergic systems that use dopamine, or serotonergic systems that use serotonin, and also glutamate, which is another neurotransmitter, and it may also be involved. Glutamate is very much involved in learning and memory as well. People with schizophrenia, and I have on that slide exactly what I said don't do, may have shrunken brains and enlarged ventricles. There is some research that suggests that yes, there is a slight difference, but that may not be that's not necessarily the cause, but may be the result after a while. Failure of neurogenesis is another. Person with schizophrenia may have a brain that's unable to continually create new neurons, and that is another important issue. So as we develop, as we grow, as one learns, as one needs to cope or adapt with one's environment, there may be maladaptive neurogenesis processes. So, and this is where normal brain continues to produce new neurons throughout life. I like this model quite a bit. It is called the stress vulnerability model, and it is a combination of environmental stress and inherited susceptibility, which causes psychotic disorders. Look, we are the universe and we are very complex, and it's very seldom there's just one singular cause for anything. And the diathesis stress model just it works. And so look under diathesis: vulnerability to psychological disorders, genetics. So you got genetics, biological processes, early learning experiences. Then there's environmental stressors, noxious physical stressors, relationship/job problems, trauma, abuse, neglect. All right, now we're going to move on to mood disorders. So mood disorders are major disturbances of an emotion. So what do we find under mood disorders? Depressive disorders, bipolar disorders. It's called dysthymic disorders. DSM-5 changed that to persistent depressive disorder, I believe. So it's no longer dysthymia. Basically, it's the same thing, though, and that is a moderate depression, low to moderate depression lasting at least 2 years. And then there's also cyclothymic disorder, which is a very sort of a low-level bipolar disorder. But it's very low level. So you see moderate cycling from mania to depression, and this has to last also at least 2 years. Types of mood disorders. There's major mood disorders, and these are characterized by lasting extremes of mood or emotion. Sometimes they even have some psychotic features. Major depressive disorder, and a lot of the drug companies are making big bucks of selling Prozac and Lexapro and what have you because of major depressive disorders. And this is a mood disorder. The person suffered one or more intense episodes of depression and serious mood changes and alterations. So we have, what are some types of mood disorders? Mania, that is a mood disorder, and that is where one sees inflated self-esteem and grandiosity and racing thoughts and agitation to the point where the person, after a while, is just one frantic ball of behavior. Now, mania, also Hollywood gets this mixed up with schizophrenia and so-called multiple personality disorder. But in fact, when you see somebody that is really bizarre on the street and doing weird things and yelling and shouting and whatever, that is probably somebody who's exhibiting bipolar disorder on the manic side, on the mania side. And in fact, people who are displaying manic symptoms appear to us, or the observers, to be quote unquote the craziest, because the behavior is just all over the place, and it's loud and a lot of times fast and wrong. Depression. It can often appear as irritability. Many times it appears as irritability and feeling worthless and having a reduced interest or feeling not getting any pleasure out of anything, not food or people or anything. It's called anhedonia, by the way. So major versus minor mood disorders. Major mood disorders are like dysthymia and cyclothymia. The major mood disorders involve more severe emotional changes. Major mood disorders also appear to be more endogenous. That is, they come from inside. Rather than something from outside causing one to be sad or depressed or blue, all of a sudden it comes from inside, like the person starting to feel blue and sad, and there's no apparent external reason for it. Causes of mood disorders, again, they are multiple. Biological. Now, the psychoanalytic or the Freudian theory is that depression is rage turned inward, not a lot of support for that. Behaviorist depression is a form of learned helplessness. Part of that, yes. Cognitive psychologists say self-criticism and negative self-talk leads to self-defeating thoughts, and therefore that may underlie many causes of depression. And yeah, all of it seems to combine in that manner. Gender and depression. Overall, women are about 50% more likely than men to experience some form of depression. usually due to social or environmental pressures or conditions. Marital strife, sexual and physical abuse, poverty also factors, but depression is more common in women. There's also something called postpartum depression. Sometimes it's also called maternity blues. Postpartum depression, though, is more serious, and it's moderately severe depression begins within 3 weeks following childbirth, and it could last from anywhere from 2 months to a year. Then there's something called seasonal affective disorder, or SAD, and I can't tell you the number of people I've talked with seasonal affective disorder. It's depression that only occurs during the fall or winter. It may be due to the change in light. It may be due to memories or reminiscences about the season or Christmas or so on and so forth. A lot of times what we call phototherapy really helps with this. And this is just extended exposure to very bright, full spectrum light, and it works. Again, the symptoms of seasonal affective disorder, or SAD, pretty much the same as moderate depression: fatigue, oversleeping, craving, ability to cope, irritability, social withdrawal, depression. And then we move into another form of disorder called anxiety disorders. Now, what is anxiety? Anxiety is a feeling of apprehension, dread, uneasiness, fear. The lowest level of the anxiety disorders are adjustment disorders, or fall within the realm of adjustment disorders. And that's where ordinary stress sort of pushes us beyond our ability to effectively cope. And in fact, adjustment disorders don't really get a bona fide DSM diagnostic disorder, clinical disorder. Rather, they're called what are called V codes. In these an anxiety adjustment disorder, there's usually some sleep disturbance and irritability, depression. Types of anxiety disorders, of which there are a few. They're just like with the types of depression disorders. There's generalized anxiety disorder. This is at least 6 months of chronic, unrealistic, or excessive anxiety about multiple things in one's life. Panic disorder is a definite type of anxiety disorder, and it feels like maybe a heart attack, or going to die, or going to go insane, or I don't belong here, and it's not a good feeling if you've either observed it or had it yourself. Panic disorder with agoraphobia. And so we're going to talk about also what agoraphobia is. What is agoraphobia? Is an intense, irrational fear that a panic attack will occur in a public place or in an unfamiliar situation. So there's movies, things about agoraphobia, or people with agoraphobia. But it is an intense fear of leaving the house or entering unfamiliar situations, and people with severe agoraphobia, like what the graphic I've got there, will not go out of the house. Many times won't even open the door. These, by the way, these certain anxiety disorders are successfully treatable. Some other specific phobias are rational persistent fears. These are like simple phobias and avoidances that focus on very specific objects, activities, or situations. So a fear of insects, for example, or spiders, arachnophobia. Fear of heights is acrophobia. Fear of water, or being in the water, is aquaphobia. Fear of being in closed spaces, claustrophobia, and of course we just talked about fear of crowds or just being outside, agoraphobia. Other types of anxiety disorder, social phobia, and this is an intense irrational fear of being observed. And again, these are treatable successfully. Another type of anxiety disorder, and one that people that misuse the word all the time, way too often used, is obsessive compulsive disorder. This is an extreme preoccupation with certain thoughts or compulsive behaviors of certain performance of certain behaviors. And these include subcategories of individuals of certain types of obsessive compulsive disorders: checkers, cleaners, and hoarders. Checkers are individuals who have to constantly go back and check. One of the problems with checkers is in driving. So if the DMV is notified or knows that you have a bona fide obsessive compulsive disorder, including checking, your driver's license may very well be suspended. And the reason is because there are individual types of checkers who, as they drive, going over any kind of bump, they'll stop the car in traffic and go back because they believe that they ran over something. Usually a child is what they believe. So this goes far beyond checking and worrying about whether or not you locked the door when you left the house or turned the stove off. Cleaners are compulsive cleaners, constantly have to wash their hands or something. Hoarders, you know what hoarding is. They've even got shows about hoarding. So obsessions and compulsions. The interesting thing, or the main thing you need to remember about obsessive compulsive behavior, is that obsession are recurring images or thoughts that drive one's anxiety level up until one performs some act that brings the anxiety level back down, like checking. Then there are things called stress disorders, and this stress is outside the range of normal human experiences. Post-traumatic stress disorder, reliving a traumatic event repeatedly, avoiding stimuli associated with the event. So just what is PTSD, post-traumatic stress disorder? Used to be called, I think in World War I, shell shock. So had all kinds of names. So but post-traumatic stress disorder, if it lasts more than a month after the traumatic event has occurred, and it may last for years. And this is typically associated with combat or violent crimes. However, research since DSM-3 has demonstrated very clearly that child abuse and both physical and sexual is cause for childhood-related PTSD. So let's look at the graphic I've got. There's top reasons for men and women who suffer PTSD. What are they? Rape, combat exposure, childhood neglect, childhood physical abuse. And that's for men. For women, rape. 2, sexual molestation. 3, physical attack. And 4, being threatened with a weapon. Dissociative disorders. What are the 5 components of a dissociative disorder? Well, amnesia is one, derealization, depersonalization, identity alteration, and identity confusion. So dissociative reactions are very clear episodes of amnesia or fugue, where you don't remember. So you go off in a certain area and there's no particular reason why that happens. A dissociative fugue is sudden travel away from home, and a confusion about personal identity. There's some the extreme cases of fugue where somebody goes out to get to buy some milk on Sunday morning, and they're never heard from again, or not heard from for 20 years or something. These incidences do happen. The so-called dissociative identity disorder, or DID, and we used to call it multiple personality disorder. Hollywood, again, really takes off on these, like the movie Sybil or Three Faces of Eve, and these are famous examples. One thing's for sure: a dissociative identity disorder starts with a horrific childhood, abuse and molestation over and over and over again. Somatoform disorders. Hypochondriasis this is sort of in a way, it's an obsessive disorder. Hypochondriasis is where a person is preoccupied with having a serious illness or disease, becomes so obsessed with this that then they go to a physician or some healthcare professional diagnoses them and finds nothing. And this goes on and on and on. Hypochondriasis. Munchausen syndrome, by proxy, is a person fakes the mental or the medical problems of someone in his or her care in order to gain attention. See, so in this case, the mom here is Munchausen syndrome by proxy. Nothing's wrong with the child, but the mom gives the child medicine in order to promote something being wrong so that she can get attention. Munchausen syndrome is a person fakes his or her medical problems in order to gain attention. A somatoform or somatization disorder is a person expresses anxieties through numerous physical complaints, headaches, backaches, stomach aches. A lot of times your healthcare professional is consulted and there's no organic or physical cause found. Pain disorders are another somatoform disorder where the pain has no identifiable organic physical cause. It seems to have a psychological origin. Now this is where Sigmund Freud started. Actually, he became interested in what they called hysteria, a conversion disorder. And this is where you have severe emotional conflicts and they're converted to some physical symptom or some physical disability. And these are caused by anxiety and emotional distress, but not physical. They're not physical causes. They're not bona fide paralysis, for example. There used to be something called glove anesthesia, where there's a loss of skin sensitivity in areas normally covered by a glove. Some theoretical causes of anxiety disorders, conflicts. Now, this, of course, is a psychodynamic idea, and it's caused by, this is always the go-to, conflicts among the id, ego, and superego. Among the humanists, they say there's unrealistic self-image conflicts between your self and your fantasized self-image. There are existential conflicts, or in other words, anxiety reflects the loss of meaning in one's life, and this can be true too. One looks out at the universe and says, I'm smaller than small. I'm more insignificant than insignificant. And when one does that and compares oneself to the universe, there's this existential, either a panic or a depression sets in. Behaviorists believe some theoretical causes of anxiety relative to behaviorists. And again, this is just any symptom behavior is learned. And so we have conditioned emotional responses, and we do, in fact, have bona fide conditioned emotional responses. If we can be conditioned to have an emotional and anxiety reaction to a conditioned response. This leads, in fact, to the types of panic disorders and phobias that we were talking about earlier when we were talking about anxiety disorders, and that is we can be conditioned to fear a certain behavior or event or set of circumstances, and so even when that set of circumstances is gone, there's a fear remaining if something similar to those circumstances occurs. In the same way that when we have a conditioned and unconditioned responses, unconditioned response like food makes you salivate, but if there's a loud honk of somebody's horn prior to the food several times, then the loud horn becomes the conditioned stimulus, and one might salivate then to that loud horn. That can easily become extinct if the loud horn doesn't produce food thereafter. But we can maintain that level of anxiety through what we call operant conditioning. How do we do that? By avoiding every place where we're going to get a loud horn. So the anxiety is is initiated through conditioned learning. However, we operantly can maintain it through what we call negative reinforcement. And then we get to an area of personality disorders. I'm going to take a quick intermission here and get back to this.